Hi, this is Vicki Eastridge, and before I start my presentation, I want to apologize for the unconventional way that I'm presenting, but sometimes you just have to do what you have to do to get it done. So anyway, I hope you can see my slides, and my presentation is about patient engagement in the acute care setting. Hospitals are being scored and compensated based on patient outcomes. I think we all are familiar with this by now. The Institute of Medicine expects that increased patient engagement in the hospital setting would empower patients to be more involved in their care. In addition, the Clinical Advisory Board reports that some hospitals are looking at electronic patient interactive tools to increase patient engagement in the inpatient setting. Literature shows, and part of the reason that this change is happening, is that patients are reporting an interest in IT tools to provide them education and information. In addition, these tools have been proven in the outpatient setting to increase patient engagement. The literature also shows, however, that nurses have not to date seen the value of these IT tools in patient education and engagement. And while practice guidelines support a standard approach to learning assessments, nurses report hesitancy to give up autonomy. So I did an evaluation of an existing program. My organization, Legacy Health System, invested about $3 million in a product called the Get Well Network. This is an electronic system focused on patient engagement and education. This project was supported by executive leaders with their initial goals very clearly outlined as improving patient experience, patient engagement, patient education, and the reduction of 30-day admissions that they hoped would come based on those changes. The initial evaluation was an interim evaluation that identified that the goals of the executive leaders were not being met. This was based on data collection that occurred as of March 2016. 62% of patients admitted had at least one video assigned, but only 20% of those videos were viewed by the patient or the family. During the same time period, only 14 patients responded to questions about their health, and 57% of the patients stated that they had questions that needed to be answered prior to discharge. In addition, direct observations were conducted. These direct observations identified that no standard process existed for learning assessment documentation, and communication between shifts for the patient education needs and the plan. Finally, there are about 5,000 videos available in the Get Well Network, and there was no prioritization established for nurses to make those assignments. So we decided to review the process again and look at what things we could do to improve the standardization of this work. The stakeholders included both direct, indirect, and supportive groups. The direct group included frontline caregivers, which were RNs, CNAs, and volunteers. And I apologize for the typo there. They weren't CANs, they were CNAs. And the indirect group included the process improvement team, the education steering committee, clinical nurse specialists, nurse managers, and the Get Well Network clinical support that helped with the meetings and the process review that we did. The supportive groups included the directors of nursing and the executive leadership team. So the purpose statement: ultimately, we will have a summative evaluation of the Get Well Network program post-implementation of a workflow improvement. The goal is to understand if the implementation of a standard delivery method for patient education improves patient engagement in the inpatient setting. So the who will be the patients admitted to the medical, surgical, and telemetry units. The what is the percent of patients who are identified as appropriate during learning assessment to take advantage then of the video education provided through the Get Well Network. And the where is the Legacy Salmon Creek Medical Center. Currently, we are planning, as I said, a summative evaluation with a mixed method design that will evaluate both the process for a standardized education evaluation, documentation, and communication, as well as the outcomes. The process evaluation will be both qualitative and quantitative, and the outcomes will be quantitative. We have two specific aims during this project. The first is to evaluate what barriers might exist to standardization of a patient education delivery process. These measurements will be interviews of the bedside nurses and observations of bedside report, as well as data collected from the EMR. And then the second aim is improved patient and family engagement, which will be measured by the percent of videos assigned that are watched by the patient or family. We have a 20-week timeline for this project that starts with training and moves to the implementation stage, and then observation and data collection, and then review and analysis of the results that will be reported back to the key stakeholders. The budget for this project is just under $75,000, which seems like a lot of money, especially for just a 20-week project. But if you consider the fact that the organization invested $3 million in this project, the $75,000 is not a significant amount compared to that. So the strengths and limitations of this project, some of the strengths are we have a mixed method evaluation that will result in what's called triangulation. Triangulation occurs when you look at a project or an outcome from multiple perspectives, and all of those things align, the results align with and send you in the same direction. This will be, like I said, process and outcomes data. And this is really frontline caregiver driven. They really participated in designing the new process, and they are very invested in the outcome. Limitations include a lack of resources to validate our evaluation tools, so we have created our own evaluation tools. We have no plan to include demographic data in the evaluation, so we won't know if a patient's age or their socioeconomic background will impact, or even their ethnic background would alter their desire to watch videos in the Get Well network. And finally, the stakeholder group did not include a patient, which I think would have been really valuable. So the application to practice, there's a significant application to practice, I think. First of all, acute care nurses can and should have a part in improving patient engagement. Education is as important to patient care as administering a medication, ambulating a patient, ensuring that their position changes every 2 hours. Education is just really important. While IT tools may or may not be the answer, nurses have to be thinking about the bigger picture. How do we influence the patient when they leave our four walls? And there's my references. So thank you very much for viewing my video and hearing about my project, and have a great day.